quelques mots pour aggraver.
So now briefly to talk about fatigue. And we won't go over everything that's been mentioned today. Let me just touch upon fatigue again, because we were very involved as oncologists at the end of the 90s, early 2000s. Perhaps we got a bit carried away with the use of all these EPOs. And then, of course, there was this pendulum that swung back with negative effects. So we were all very scared, and we all retrograded, and we don't use EPOs anymore. We don't teach it to our young interns. So either they are underused or badly used, and that also has a negative impact on patients. That's also a problem. So we need to communicate once again on EPOs with everything that we learned later. Now, this is referring to what you mentioned earlier. And oncologists, particularly end of 1990s, early 2000s, if we asked them what are symptoms of cancer, it was pain, 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 pain. And then there was this publication which shook us all up, because instead of asking questions of doctors, we asked patients. And we realized that what bothered them most was not really pain, it was fatigue. And so that obliged us to take a second look at fatigue. And it is true, when you talk to patients, you find that a patient who has cancer, in 2 out of 3 times regularly on a daily basis, or 3 or 4 times a week, talks about fatigue. So that caused us to open our eyes wide, and we felt, hey, we have a problem here with control and management of fatigue. Now, it's quite clear that fatigue and anemia, everyone tend to make that shortcut. Everyone feels fatigue. Fatigue is not just related to, of course, anemia. There are several other causes, and you're experts. I'm not going to teach you about this. But quite clearly, there was a link between anemia and fatigue. We also realized that this was the first market certification for EPO, so transfusions were a bit frightening. So if, as far as possible, you could avoid transfusion, it would be better. If there is, they said, the reason why it was cleared finally for sale was that it helped fatigue. And second reason was quality of life. Virtually 60 to 70% of patients, when they had anemia and fatigue, particularly platinum-based chemotherapy, we had that second certification to use EPO to fight anemia, and as a result, fatigue in patients treated for cancer with chemotherapy. And why were they better? Because instead of having all these spikes of hemoglobin, we had a sort of stabilized, regular level of hemoglobin. So quite clearly it had an impact on quality of life. So that was the second certification that was given to EPO. And then it was easily proven that improved the quality of life. And then once again, everyone got carried away by the use of EPO. Very good for quality of life, very good for anemia. And so it was massively prescribed in around 2002, 2003. Now, when we did the study, we did relate hemoglobin to quality of life. And it's true that quality of life scores deteriorate, when you're at 10 or 11 grams of hemoglobin, and the threshold values between 11 and 13. So we were slightly more convinced by our figures. So we didn't want patients to be below 11 grams. And we always had to make sure that this rate be at around 11 to 13 to give better QoS to our patients. Now, this was true to a certain extent, and it was 10 years ago, and you don't reinvent things, but it's a great pleasure to see that anemia, fatigue, and so on are again part of the concerns of oncologists. In the latest European Oncology Institution, there was a debate on anemia and fatigue. They added certain other ideas, but it was for me just a reminder of what was done 10 years ago, a more updated reminder. Again, all symptoms of anemia were reassessed. So when you're tired, that's the master symptom. But there's several other symptoms too, which are described, all that we know of in medicine. And quite clearly, if you give EPO, prescribe EPO, and in this case it was you correcting the hemoglobin rate and also quality of life. So in this publishing, that's what must be kept in mind quite clearly. When you're assessing a patient, you being administered EPO in 100% cases, roughly, you improve hemoglobin, 60% success in anemia and hemoglobin score. So when you give EPO in 50% cases, you improve the QoS in their questionnaire, you improve that score. And then, strangely enough, there's no perfect superimposition because you have just 40% cases where there is an improvement in both hemoglobin and quality of life, almost as if EPO, apart from hemoglobin, could also boost patients who felt better without the hemoglobin really changing. So if you do correct the hemoglobin for most patients, you do improve quality of life. This has been clearly demonstrated and validated. It's still true in 2014. Let's not forget, 10 years later. In 2002 and 3, we got carried away because we did gigantic scale studies. And sometimes the effects were rather perverse because we felt that if you improve QoS, we can do more chemotherapy. If we improve hemoglobin levels, when you do radio and chemotherapy, then you can really, it gives a sort of oxygen effect. So the hemoglobin content and anemia relations were not very realistic. It was more than 50% hematocrites. And if you look at the meta-analysis, the consequences, of complication rates related to the administration of EPO, perhaps because of some unrealistic goals and clearly a great rise in thromboembolic events. So perhaps we were unreasonable, and as a result, it led to a deficit in survival if you gave huge doses of EPO in an uncontrolled fashion. So by trying to do too much good, we were doing bad. So there was a study that was carried out. Now, if you give EPO as an adjuvant, the idea would be that through this you improve patient survival. You'll cure more because you'll do more chemotherapy, and you won't reduce doses because patients won't be tired, and so you can push further. This study had a terrible impact because there were more complications with EPO, which were given to all independently of hemoglobin content. So there was a bit more thrombosis, more complications, and some more events. So it's a negative study. It shows absolutely no survival benefit. Today we are saying it's not reasonable, but at that time we just got carried away. Plus, there was also a problem with the safety in the use of EPO. Apart from this study, others were also willing to, backpedal because there was a doubt about another adverse effect of using this family of molecules. Now, in practice, if you mix everything up and if you do a huge meta-analysis, and you can do that because there have just been so many studies, you realize that there's no negative impact if you use EPOs correctly or properly. If you look at all survival rates in all the studies in cancerology, on the whole, the impact on survival is close to 1. With or without EPO, the survival rate is the same. In these same studies, you have some very unreasonable studies with huge high limits of high hemoglobin rates. You do it with this rate as opposed to best supportive care. We've improved their QoS, and if you give them EPO outside of chemotherapy, gives them high hemoglobin, but it didn't improve them because you increased all the thromboembolic events. So quite clearly we got carried away. But when you compare everything, you have to be honest. You realize that you shouldn't be either carried away or underuse it. Clearly, impact on survival is 0 with EPO. But it is not negative if it is properly used. And if it's properly used, then you must take a second look at criteria. In some of the major studies, like this one, the green line with or without EPO, they can be superimposed for survival. No one will see a difference, even if you're very critical. You can be reassuring and say there's just no impact. So use and recommendation have changed a lot. Look at 2008, in February 2008. In 2008, we had restricted our fervor because we had said that we were too permissive in the past. And therefore, you have to come down to 11. Earlier on it was 12 or 13 hemoglobin, and target hemoglobin, there were no limits in 2008. And we felt that we had to be a little cautious, and above 13 one might even try to stop the treatment. But in practice, after 2008, we've become a lot more reasonable in our attitude. Start EPO at 10 and use target between 10 and 11, and you don't stop it if it you stop it if it goes above 13, and if it reaches all the target values, you try and maintain it between 10 and 12. These are very simple recommendations, very reasonable, which were made at a European level. But if you look at NCCN and so on, they're all virtually giving the same recommendations. EPO, but not at all cost. And with chemotherapy, 10 to 12 for hemoglobin, and not much, and no need in continuing if they're higher than 12. So if you do that, you do solve a lot of problems, because the anemia rate in breast cancer with adjuvants is in 60% patients, 60% who feel they're very tired, and that is associated to clinical anemia. So depending on chemotherapy doses and on the body surface kind of chemotherapy, this incidence can change. So anemia and fatigue is still a problem today. Proper use of EPO might probably help in correcting certain factors. And let's be honest, we have adjuvant studies too, particularly with NEST, which compares the use of EPO for adjuvant chemotherapy as opposed to non-use of EPO in early chemotherapy. Not the TAC, which is the most hematotoxic, and objectively, with or without EPO, survival rates show progress, and they are virtually the same. There is absolutely no negative effect in giving EPO. The only point is that you're actually changing quality of life, that you're removing a large amount of fatigue, and people receiving this chemotherapy lead a better life, live better. So it's worth using EPO. So my point is, yes to EPO. It was a progress. And yes, we overdid it in oncology by administering it at a very high dose and much too early with absolutely over-ambitious goals. So now, forget those past fears. Let's get back to good practices. Let's be reasonable. And when you do that, it's only reasonable to use EPO, because it's indispensable for a better quality of life. Let me remind you, when it's at 10, start at 10 of hemoglobin and try not to go over 13. Mustn't do that. Also, use appropriate dosing, depending again on the hemoglobin content. Leaving it, I repeat, between 12 grams. So that's roughly about the use of EPO in cancerology. Before I give the floor to Laurent Zelek. Unless, of course, you want to have some discussions. Maybe you're tired. Maybe I was very toxic. Go on, shoot your questions. I can see some people have raised hands. Laurent, I can't find your presentation, by the way. Okay, it's the last one. Sorry, we can't hear the question. Answer. There were warnings about the use of EPO in Europe as adjuvant for breast cancer. It was very clear in its entitling. I think you have to be extremely cautious. I'm not saying you should make it a rule, but at the same time, stopping a treatment because there's just too much fatigue and that quality of life has deteriorated is also very negative. You must strike the right balance. And in certain cases, I really don't hesitate to prescribe EPO for breast cancer and CT. But I always discuss it earlier before I validate it, and it's nothing exceptional. In cancerology, and particularly breast cancer, a lot of progress has been made. Today we have chemotherapy which is less toxic compared to what we had in the early 2000s, where TAC was really very toxic, so the impact is less. Sometimes it is there, and sometimes a patient experiences a disaster. So when we have something to offer, we say there were restrictions in the past, we inform them clearly, and then we validate it with the RCP. And we say that it has to be something that is in line with their quality of life. Well, we didn't come to an understanding on this, but I'm going to repeat the same thing, because if you prescribe everything as adjuvant, in a month you'd get to a threshold where quality of life would be very good. We haven't explored this, but let's not forget. I know we'll be talking of fatigue, but adjuvant cancer is 1 year of fatigue for some women. So when they're at 9 grams at the end of chemotherapy, adjuvant chemotherapy, we are adding more, and it's an added burden for them. So if you inform them correctly, I really don't think that 4 weeks of EPO would lead to a tumor, honestly. No, I'm not worried about that. I think the important factors are also the duration. Sometimes it's better to treat over a few weeks, give a few injections of EPO to correct the symptoms rather than increase the dose over a much longer period of time. Because concerning fatigue, you have to talk to them, you have to explain to them. A lot of patients say, no, I'd rather just stay in bed, but I don't want an EPO. Yes, you had a question.
That the pendulum has swung way too far both ways. But we have to be very careful in how we word things.
Yeah.
Remember that when we admitted that the variation in fatigue in cancer patients has only 16% of it explained by variations in hemoglobin. So we shouldn't use adjectives like this is a major impact on fatigue. That's not what those data told us. The data said it was a small, important part of the puzzle.
I completely agree with you. It is not a full overlap between the hemoglobin level, the correction by NES, neurocommon, what you want, and the fatigue. Obviously, there are some things in the room that we don't understand, but it is not only one factor, hemoglobin, fatigue, erythropoietin is not so simple. I completely agree with you, and even with a decrease of hemoglobin at such a level that you decide to propose some erythropoietin, if the patient doesn't experience any fatigue, it's probably not a good indication. I completely agree with you.